Yes, sir, we are live. We can start the meeting. Yes.
So,
So,
Rajiv sir.
yeah, welcome all. And this is a monthly webinar of Indian Arthroscopy Society. And I would like to thank Dr. Neha, Dr. Sridhar, and Dr. Naresh for organizing this wonderful webinar on Friday. And special thanks to Dr. Laurie and Dr. Rohan for joining from Canada and UK. So, uh, it's like we telecast this webinar in our YouTube channel. So we will have a case discussion also after lectures and case-based discussion. So looking forward for a great show. Over to you, Dr. Neha.
Thank you, Dr. Rajiv sir. So, greetings to one and all, and welcome to Ias Academic Corner webinar May 2025. Thank you to our IS President Dr. Arumugam sir and IS Secretary Dr. Rajiv Raman sir for joining. So today we'll have three case presentations by our IS members and an expert talk by Dr. Laurie Himstra. Dr. Laurie, I would like to introduce her in brief. Dr. Laurie is an orthopedic surgeon at Bath Sport Medicine, Canada. She is a clinical associate professor at University of Calgary, Department of Surgery. She is a director of research at Bath Sports Medicine Foundation. She is assistant treasurer of ISACOS and past president of Canadian Orthopedic Association. And she's a past chair of Gender Diversity Force at ISACOS. And she has a phenomenal work in patellofemoral joint. So we'll be experiencing about her work in a few minutes. So our moderators for today are Dr. Miten Sheth. He's a consultant arthroscopy surgeon at the Knee Clinic, Mumbai, and Dr. Rohan Bidwai, a consultant orthopedic surgeon at Southmead Hospital, Bristol, UK. So welcome both the moderators. And from now onwards, I hand over the proceedings to our moderators, Dr. Miten and Dr. Rohan.
Hi, thank you, Rajiv sir and Neha, for the introduction. It's really special to share online screen time with Dr. Laurie. She is like a true inspiration to any and every knee surgeon that I know of, especially me, really big fan. So it's a true privilege to have her with us. Rohan and I have studied together, so it's very nice to reconnect after a very long time. So, Rohan, hope you're doing well. And we have an
Thank you.
exciting lineup of talks today. Looking forward to learning a lot. So, we'll start with Dr. Laurie, and let's begin.
Okay, does that look okay?
Yes.
All right, well, thank you. Yeah, thanks everyone. I feel like I was actually just in Pune about 2 or 3 weeks ago, and it's really nice to see everyone again. I feel like I have lots of connection with India these days, so that's my benefit for sure. So I've been asked to talk about first-time patella dislocation, and I think this is a really, really important topic right now because I think if you read a textbook or you read some older literature, the thinking around first-time patella dislocation is changing quite rapidly right now. There's lots of new research coming out. We're becoming much better at assessing patients and understanding the patient as well as the surgery that we do. So I think it's a really good time to revisit how we treat a first-time patella dislocation so that we stay in the new way to treat things and not just the old way. So these are my disclosures. First, I just wanted to talk a little bit about nomenclature and how we describe things. So at the International Patellofemoral Study Group, we're actually working on a Delphi consensus on nomenclature around the patella. And it actually was funny because I went through some older talks I did on this, and there's actually within the talk, I called an acute patellar dislocation 3 different things. So, and to me, these all mean the same, but I think maybe to everybody, they don't mean the same. So I just wanted to put this up first. So an acute patellar dislocation is often used as a first-time dislocation or a primary dislocation. So when you read in the literature, you'll see all 3 of these terms. used for a first-time patellar dislocation. I've tended to try to stick to first time because to me, acute means it just happened and I might have dislocated my kneecap 20 times, but if the 21st time just happened, to me, it's pretty acute. But that may not be what we mean in the literature. So I've tried to stick to first-time patellar dislocation because I think that describes it the best, but just some little things to keep in mind. So there, and I just said it wrong on my first slide. I didn't change it on this one. So for first-time patellar dislocation, actually a very, very common injury, especially in children. And it still amazes me how often I'll get adolescents or older children in clinic that were seen in emergency. And every time someone hurts their knee, it's always a meniscus tear. And if it's not a meniscus tear, it might be an ACL. But if you look at the literature, this is out of Sweden. Marie Askenberger, a very good friend of mine and a member of the IPSG, they looked at they actually looked at children that came in with a hemarthrosis, and then they MRI'd them. And what they found, which mirrored other work that was done in the United States, they found that actually the most common reason for a hemarthrosis in a child, so let's say under 16, under 18 was the other paper, is actually a patellar dislocation. So to me, that means if a patient has a hemarthrosis and a knee injury, the first thing we should be thinking is a patellar dislocation. In my experience here, that's not the first thing people think. They think meniscus tear, they think ACL. So understanding who a patellar dislocation occurs in and how they present is really important, because if you don't think about the diagnosis, you're not going to get the diagnosis. So let's look at age, because age in patellar dislocation is really, really important. And you'll find this in first-time dislocation as well as in how patients do after we stabilize them. So if you look at first-time patellar dislocation in children, very high incidence. And this follows what Marie Askenberger showed us in her study. So somewhere over 100 per 100,000. So very, very high incidence. And if you look at those patients and follow them over time, multiple studies over many years have shown that there's a very high recurrence rate. Of course, there's always a range, and we'll talk about why there's a range, but this range, I mean, the middle of this is something like 50 or 60% will recur, even if you take the average of that. So it is an important thing to diagnose first, because our goal in orthopedics is, one of our biggest goals is to prevent secondary injury. So if you don't diagnose the first injury, it's hard for you to try to prevent their second injury. And over 50% of these children will have a second injury. What happens when you get older? Well, the incidence is still fairly high, but not as high as it is in children. And what you can see in some of these studies that show different age groups of adults is the older you get, the first time you dislocate your patella, the less likely it is to recur. So the incidence goes down and down and down, and the rate of recurrence goes down and down and down the older you get. So I figure I'm pretty safe at this point. And this has been shown in lots of studies around the world. So how do we know which patients will recur? I would argue that somewhere around 50% is a very high recurrence rate, but can we tease that out? Can we figure out when we see the patient, when we look at their imaging, when we examine them and talk to them, can we figure out who in that group is more likely to recur than others? Because nobody likes to treat every patient the same. We like to try to pick out who's going to do the best with our treatment. So there have been multiple studies that look at it, and just to boil it all down, essentially, the younger you are, the more likely you are to have a recurrence. If you have trochlear dysplasia and if you have patella alta, more likely you are to have recurrence. And these make sense. So if you have a lot of risk factors, you are more likely to have a dislocation at a younger age than someone who has no risk factors. So these all they all fit the story of patients who have a lot of risk factors will dislocate at a younger age. Therefore, if you dislocate at a younger age, you're more likely to have risk factors. And then things like valgus alignment, lateralized tubercle, generalized joint hypermobility, those also play a role, but the three big players are age, dysplasia, and alta. So once we know a little bit more about what are the risk factors that make people recur or make people at risk of recurring, we can then create equations to help us figure out if we can take a certain patient, plug some of their information into an equation, and give them a risk score and stratify them as far as risk goes. And there's been a couple of these published. This one came out of Germany with 4 very good patellofemoral surgeons. And again, they called this the patellar instability severity score. There's one of these for the shoulder too that was made in France. But again, they put age in there. So again, age gives you a score. If you're under 16, you get a point. Bilateral fits with having more risk factors. Trochlear dysplasia, patella height, groove distance, and tilt. So they've taken those big risk factors and assigned a score to them. And do you see the only one that has a score where you can get 2 points is trochlear dysplasia. So trochlear dysplasia is a big player in recurrence of patellar instability. The problem with patients with patellar instability is they never have just one of these risk factors, right? There's very few people who have only dysplasia and nothing else. So this is in that same paper, but they took it from a paper out of the US, from the guy I did my traveling fellowship with, Sheetal Parikh. They looked at how many risk factors patients have. So not only what risk factors, but what happens when you have 2 risk factors or 3 risk factors or 4 risk factors. And you can see now with the mean predicted risk of recurrence on the outside, if you have no risk factors, your risk for recurrence is pretty low. If you have 4 risk factors, it is almost a sure thing that you are going to redislocate. So again, which risk factors you have, they make a difference. And again, what combination of risk factors and how many you have is going to make a difference. This fits really well in with some of our research out of Banff. We introduced this about 10 years ago now, but this was the same idea. It was before these other severity scores came out, but we looked at it, and I was a shoulder surgeon. Also, back then, I was still doing shoulder. And the patellas really reminded me a lot of the Tubbs-Ambry classification. So you get those traumatic shoulder dislocations, and then you get the loosey-goosey people. And I really found when I was seeing a lot of patellas that it reminded me of this, seeing some of these patellas, right? They dislocate when they're walking and they're really loosey-goosey and they don't have great muscles and they tend to not do well. Those are the people that if you plug their data into that instability severity score, probably score quite high. And then our stayed patients who are super strong, you know, they were playing cricket and got smashed in the knee and they dislocated, so traumatic dislocation, they actually tended to do well, similar to your stayed patients in the shoulder. So these are all people in different parts of the world thinking the same thing as we start to see more and more patellas and treat them more. So when we see our patients that dislocate for the first time, these are all the things that should be going through our head. There's quite a lot published on first-time patella dislocation, and there's actually quite a lot published out of Scandinavia that's a lot older. It's still very good research, but it's a bit older. And then recently, as I said, there's been a rash of new publications on first-time dislocation. This one I found is one of the best, not that the others are not good, but this one really covers it. And this was the ESCA consensus, and this was just published in late 24 and 25. So they have part 1 and part 2. So if you are interested in really the most up-to-date thinking about how to treat a first-time patellar dislocation, I encourage you to read both of these articles. They're a nice, easy read. They question format. It's a consensus from the ESCA Patellofemoral Study Group. So this is a really nice, succinct way to catch up on everything. And much of what I'll talk about is contained in here too. So what happens? What should we be doing? Okay, I've said we need to treat first-time patellar dislocations better. What should we be doing? So I can tell you that this does not happen in Canada. So you will get AP, lateral, and oblique views, because in Canada, that's trauma views of a knee. So if you get a knee injury, you get trauma views. Very rarely will you get a skyline. Having said that, if you have a big, huge effusion and a recently dislocated patella, it might be a bit difficult to get in the position for a skyline. But any of you who treat patellas will know that the skyline view will give you a lot of information, especially with regards to osteochondral fractures. I've been fighting that all first-time dislocations should have a relatively urgent MRI, so within a few weeks. I do not get this in Canada. Don't by any means think that. But the reason is there's two very good reasons to get an urgent MRI. First, this is a big injury. We already talked about that these present with a hemarthrosis, and you don't get a hemarthrosis without significant damage to your interarticular structures. There are a lot of osteochondral fractures that if you do not get an urgent or pretty quick MRI, you will miss. And we know that up to 40% of these patients have an osteochondral fracture. The new data coming out of the Jupiter study in the United States is showing that over almost 15% of patients have a repairable osteochondral fracture. The other reason is we also know that at least 50% of these patients are going to need to be fixed or stabilized down the road. If you can get their MRI early, you can do a proper risk stratification. So you can assess their risk factors. You can see if they have trochlear dysplasia. You can see what their TTTG is or their TTPCL. You can measure all these things. So now we have early good information so we can stratify the patient as per risk. We have all the information we need if we want to surgically manage them, and we're not going to miss all those osteochondral fractures, which are really important to catch that I think we are not catching unless we get an urgent MRI. So there's our high. That osteochondral fracture, very important, 25 to 40%. Given how we think about hemarthrosis, maybe even if you don't know it's a first-time patella dislocation, you might misdiagnose the injury as an ACL, so the MRI helps with diagnosing it. But ultimately, we want to save that cartilage. So we know in studies that if you fix that piece of cartilage, the patients do really well. So 83% success rate for fixing that piece of cartilage. I can tell you that I don't get to fix that many of them when you see them 8 months down the road and that piece of cartilage has been floating in their knee for 8 months. So the best treatment for cartilage in these young patients is to fix those. So again, if we have our x-ray, if we can see that osteochondral fracture, we need urgent MRI and we can fix the fracture and hopefully save the knee. So this is what we were taught in the past, right? I took these quotes right out of not even that old papers, right? But there's no evidence that surgery improves outcome over non-surgical management. We should treat all first-time dislocations non-operatively. The only time we should treat a first-time dislocation is if there's a fixable osteochondral fracture. And this is probably what I probably taught this a few years ago, but is that true or is that not true? And that may be what the literature showed us in the past, but not all literature tells us the whole story. So I'd like to challenge everybody to rethink that a little bit. Non-operative management, we can't even agree what the non-operative management of a first-time patella dislocation is. This is a systematic review which came out of England, a bunch of very good guys out of England. And their conclusion here that, I highlighted a bit wrong, but patients who have non-operative management of patellar dislocations do not return to their pre-injury function, and the pooled redislocation rate was 30%. So again, it all depends what your outcome is. If your only outcome is redislocation, I think most of the studies have shown that if you operate on them, they actually redislocate less. But it's not only about redislocation. I can stop my patella from redislocating if I never play sports again and I give up all my activities and I wear a brace all the time. This does not mean that these patients have good quality of life. So we need to think not only of redislocation, but of quality of life of these patients. So we know if we treat them well non-operatively, they can improve, but they don't get all the way better. And how are we treating them non-operatively? Some people ignore them and just send them away. In Canada, you'll get stuck in a brace, locked in extension. And you know what? Your kneecap will not dislocate if you lock them in extension, but your muscles will shut down significantly. So in 6 weeks, you'll have a sublux patella that's healed in that position and you'll have no muscle firing and you'll have to do a whole bunch of rehab to try to get that back. So you're really starting behind the start line there. We've started a little experiment bracing people 30 degrees to full flexion. The theory being in 30 degrees, your patella should be in the groove if you have any bony stability in your groove. And therefore, at least the MPFL will heal in that shortened position. But Patients really don't like being stuck with their knee bent because you can't really weight bear in 30 degrees. We let them move so their muscles will fire, but it's actually not very tolerable for the patients. It makes biomechanical sense, but it's not too tolerable. Can we do a bit of both of those? Like, have we figured out our best non-operative management? There's a lot better braces out now than there was 10 or 20 years ago. Can we combine some good PS bracing or some good taping and to try to keep that patella in the groove so that the medial soft tissues can heal with the patella in a reduced position? We should be referring these patients to physio immediately. There is lots of use of EMS and other things that physios can do to try to decrease that muscle inactivation. So the muscles really shut down very quickly if you don't use them. So we want to maintain their muscles firing and allow the MPFL to heal in a good position. So I think we don't know our optimal treatment for non-operative management, but it shouldn't be conservative. I hate the word conservative management. It's not conservative. It's very aggressive non-operative management. So there is a rule for non-operative management for sure, but make sure you're aggressive at getting that MPFL to heal in a good position and getting those muscles firing. So here's the big question. When do we operate? Well, this is what we do know. If you have a fixable osteochondral fracture, you should fix it. And just like anywhere in the body, if you fix something, you should stabilize the joint. So we would never do a big meniscal repair and not do the ACL reconstruction to stabilize the joint. We shouldn't be fixing a big osteochondral fracture and not stabilizing the patella to protect our repair. So I think everyone agrees on that one. That one doesn't have too much controversy. Where the surgical management for first-time dislocations is going now is it really doing a good assessment of those predisposing risk factors and assessing the risk of recurrence. And people are getting much more aggressive at early surgical management, especially in people we know have an 80% chance of redislocating. So if we know that risk is high, and then of course, depending on the patient characteristics and demands, we're getting much more aggressive at early fixation and stabilization of first-time dislocators. And this follows the same pattern we had with ACLs. When I was a fellow, if you were an Olympic athlete, you got an ACL. But if you were like me now, you would never get your ACL repaired or reconstructed, right? We always did the elite athletes, and now we do everybody. So I think this is the trend that's going with first-time patellar dislocations. Quickly on what procedure to do, I think this is becoming very clear. There's a lot of old literature on old techniques to fix patellas that was very valuable at the time, but is maybe historical at this point. We know that medial reefing procedures, non-anatomic procedures really don't work. So we shouldn't be doing them. Just repairing that MPFL, we don't know where that zone of injury is. Just repairing the MPFL acutely does not seem to work. However, if you know where the zone of injury is, if you know that MPFL came right off the patella, then sometimes repairing right in the correct zone of injury may work. And especially in the when there's minimal risk factors. So if they don't have dysplasia, they don't have ALTA, they have great tissue, and you know where the zone of injury, repairing that will do fairly well. But all in all, we've gotten very, very good at MPFL reconstruction. This is not a big procedure. This is quite minimally invasive. And MPFL reconstruction, when you're going to stabilize, really should be your stability procedure of choice. So here's a summary of our surgical decisions. We want to assess the injury, right? We need to make sure they dislocated the patella. We don't want to miss any patella dislocations. We want to find out if there's an osteochondral fracture amenable for fixation. And if we're going to fix the fracture, we should stabilize the patella. We want to assess that risk of redislocation. So really, we want to put our money where the best bang for your buck is. And those are the people that are at the highest risk for recurrence. And non-operative management is not conservative. But we want to brace and we want aggressive rehabilitation. If you're going to operate, do an MPFL, and then depending on the other risk factors, add other procedures as needed. And our goal is a one-time journey to the operating room so we can correct everything all at once. And I will stop there. Thank you.
Super. Thank you so much for your talk, ma'am. I have two questions. One, we see these kids, say between 10 and 14, when they are young, skeletally immature, and they have risk factors, say more than 4 risk factors. Most of them have trochlear dysplasia. We know that we can't offer them any bony procedures. We are offering them surgery because they have a lot of risk factors, and we are going to do an MPFL reconstruction. So they are actually the WOPs, the loosey-goosey ones.
Mhm.
How do you think they fare with just MPFL reconstructions, considering you're offering trochlear dysplasia surgery and tibial tuberosity surgeries in adults when they have the same risk factors, and you say that a plain MPFL doesn't work?
Yeah, that's a really hard problem. So there are some procedures you can do in skeletally immature. So if rotation would be a big one, I find a lot of these kids rotate, like the younger they are, the more rotation tends to be one of the risk factors. And you can do derotation osteotomies in children. There are some modifications of the TTO, and I'm not a pediatric surgeon, but there's your you have to remind me what they're called. I
So we
always
can
forget the
do the
names.
4-in-1 and the Rue Goldwaite and stuff, but
The
there
Rue
are
Goldthwait
younger
and
ones, right? So we're talking about adolescents, like between 12 and 14. It's tricky. We know that they have a bad trochlea, but we're just doing an MPFL.
yeah, yeah. So
But
the
in your
trochleoplasty is the
experience, has it worked for these patients?
so in my hands so far, no. So I did a bunch where I'm like, okay, if I can keep the patella in the groove even for a couple of years, there's definitely literature that shows if you can get the patella in the groove, it'll help form the groove better.
Okay.
Right. So that's but they've all failed, and I've got them to adolescence, and then I've done a trochleoplasty or derotation. So I think being aggressive with the concomitant procedures that we actually can do in peds. So there's a few papers looking at patellar tendon shortenings, looking at the different reimplant patellar tendon. I don't do those, sorry, the peds ones, I always forget their names. There's a couple different ones that several pediatric orthopedic surgeons have been using with good results. So, to address the lateralization of the tubercle issue. Um, so, and then the rotation, I think, is a big one because you can address rotation. And then trochleoplasty, we've now been doing if they're within 2 years of finishing growth. So some like closing growth plates, we've essentially gone ahead and done that. And there's been some published good results with that. So,
Great.
but those are very difficult
One more
patients. So
short
again,
question. Uh, do you use the Donjoy True Pull Light? I mean, these are those shorter braces with the short stick just on the lateral side of the patella. So it's like a band with just a
yeah.
hard thing on the lateral side. You
I think there's a lot of different PF braces. I think there's probably a lot of good ones, and then there's a few like really useless ones. So I think if you use one of the good ones, you're good. Our favorite actually right now is the Bauer Find. That's what we have in our clinic because it's got some nice compression,
how do you
but
spell
definitely
that, ma'am?
Bauer Find. That's the one I showed, the gray and blue one. They're for German, BAUERFIEND.
Okay.
They're nice because they have compression. They have, but some people don't like them. So, I think as long as there's one of the good ones, I think those tiny little ones that just cover their kneecap aren't going to do very much. I think you need some length to it. So, yeah. Nia?
Yeah. Hi. There is a question on live chat. Dr. Pratima wants to ask, in your experience, is there any surgery that we must not combine with MPFL reconstruction?
Any surgery that's not necessary?
Or which
You mean an open growth
not
plates or?
combine?
Okay.
To me, it's always about balancing the risks and the benefits. So, I approach the patient, I find out all their risk factors. And I don't know if you're on the webinar yesterday, and Shiana Main had that little chart, right? She has her little chart. These are the risk factors. These are the numbers. She highlights these that are abnormal. So I do the same thing. And then you pick what you want to do, what you think you need to do to create a stable knee. Obviously, we don't fix every abnormal value to perfect. You don't need to, right? You need to fix the most important ones. And then you have to assess what the patient will handle. So if what you want to do sometimes is a femoral osteotomy, tibial osteotomy, derotation, trochleoplasty, MPFL, they'll never move their knee again. So if you really feel you have to do that to stabilize the knee, then you stage it, or you pick your you pick ones that you can do and see how they do, and do a second stage if necessary. So I think it's always about risks and benefits. But if you don't do enough surgery to get the biomechanics right to keep the patella in place, you'll be back. And how you stage that is sometimes that's the art of it. Sometimes I look the patient in the eye and go like, they will not handle a double level osteotomy. There's no way. So then I pick the lesser surgery, leaving room to come back if you need to. So I think it's always balancing. There's never a right or wrong answer, unless the wrong answer is you're doing a surgery that's not necessary.
Okay. And one more question is, how would you define a fixable osteochondral fracture pre-operatively?
Yeah.
So that's a difficult part sometimes to assess pre-operatively whether this patient needs fixation or not.
Yeah, so
Is
what
there
that ESCA guideline says is a square centimeter. But then they say, because no one knows, right? So then they say the younger the patient, the more aggressive I would be. So, and again, I think it depends a little where the piece comes from. We've all seen those ones on the femoral condyle. They're way off to the side. They're not weight bearing. I'm not too fussed about those, but some of those extend all the way or extend onto the weight bearing surface. I'd be much more aggressive with those. So, in my mind, it's the same thing. I would rather err on the side of trying to fix them. And if you go in and aren't able to fix them, it's better, and then still stabilize them, and then at least you're done with them, hopefully, until you have to do your cartilage restoration. I had one though that was in like 10 pieces, and I actually took the biggest pieces like a puzzle and put them in, and it certainly didn't fill in the whole defect. But I think of how we do osteochondral allograft transfer, we don't always fill in the whole defect if we can't. So I think even doing the best you can for a young person, as much cartilage as you can save, the better.
okay?
Dr. Lowry, what is your preferred fixation device for osteochondral fragment? Biopin or sutures?
Yeah, so I use a smart nail, a ConMed smart nail. So they're little tacks, but they have this tiny little head, and they have the barbs, so they compress. So they have compression. They're super easy to use. I have access to them, and they're only like they're 1.5. They're very small.
Have you had any post-operative MRIs done after your BioBrace MPFLs?
No, not no, not post-op yet.
Okay.
The study patients will get them post-op, but I don't have them a year out yet. So
Right, but no short-term complications or scary things, right?
no, BioBrace has been, I've had 0 adverse events with them.
Hi, Dr. Laurie.
Hi.
It was an excellent presentation. Thank you for that. Just on continuing the theme, what Dr. Mithane suggested about deciding the timing of surgery for a patient who is adolescent, and that you would contemplate a further bony procedures on them. How do you go about deciding the timing eventually? I mean, do you wait for them to go back to the sports, redislocate further, but that puts them at risk of further cartilage injury?
Yeah.
As they go along, and what's your goal? I mean, how would you decide in that way? You say the patient factor, those who are athletic, those would need
Yeah.
further.
Yeah, it's a great question. So, patellar instability is annoying, but it's not cancer, right? So, really, unless it's an osteochondral fracture, nothing is urgent. So I base it on 2 things. One is how coping are they? So there's some people that have recurrent instability, but when they wear the brace, they can actually play their sport and they're doing fine. They just don't want to do that forever. And there's some that are like, they can't play, they're off and they're off their sport already. So if they're off their sport already, it's easy. I'll do them as soon as I can. If they're actually functioning well enough to play their sport and their sport is important to them, more important, then I give them the choice. Like, the reality is they're not going to die from this, but the risk is they could beat up their knee more. So I always tell them, if you're playing practice and you think you're coping and you have your brace on and you're not dislocating, but you come home from practice every day and your knee is swollen and it hurts and you're limping around, you're beating up your knee. So you may not think, dislocating is not the only bad thing that can happen to your knee. But if your knee's pretty quiet and you wear the brace and you're doing okay, then I'll time the surgery for the end of their season so they have the longest recovery rate till their next season.
Thank you.
If you have a patient
Okay.
that's pretty stable, has a traumatic dislocation, but is an elite athlete, for example, we have hockey as a sport in India, and the patient's a goalkeeper, so they need to do a lot of side lunges, which are at risk
Yeah.
positions.
Yeah.
Post the rehab, the patient's doing really well because it's not a warp, right? The patient has just had a traumatic dislocation and now is coping
Yeah.
with that 2 months and 3 months. Do you
Mhm.
ask them to change their position, or would you offer an MPFL for subtle anterior pain and discomfort?
Yeah, that's a tough one too. And again, patient specific. I mean, look at Patrick Mahomes. He dislocated his kneecap and non-operative management. He won 2 Super Bowls.
Yeah.
So I think it really depends. It depends where they are in their career. It depends, what their current symptoms are. Uh, the, the real thing is if you treat them non-operatively, the risk is they dislocate again, and now they're out for the season. So if people have seasons, they'll tend to not want to risk a dislocation early in the season and then be out another. So again, if a straightforward MPFL is a pretty benign procedure, if you do it well, I would encourage them, that could be theoretically preventative. But again, you have to gauge. If it's a recreational guy, I would say I can't make you better than you are. If his whole professional career rides on it, I mean, you just have to judge it. I think it's not unreasonable both ways
Right.
to approach it.
Super. Wow. I think we're going to have a million questions. So much to ask,
Right.
but I think for the want of time, we'll move ahead with the rest of the session. So
Okay.
next up, we have,
Thank you.
thank you so much for your time and for the brilliant
Thank you.
presentation. Thank you.
Thank you very much. Thank you.
So we have Dr. Aditya Chaube, who's going to present a case again related to a kid with a patella dislocation episode, first time. Yeah, Aditya, if you can share your screen, please, and start your presentation. Okay, if you'll unmute yourself, then we can hear you as well.
Good evening, everyone. You can hear me now?
Yes, we can.
Okay. So today I'll be presenting this case of a traumatic patellar dislocation in a child who had genu-valgum. I'd like to thank Miten Sheth sir for sharing his case with me for me to present it today. Sorry, the slide is not moving.
You can
Yeah,
try using your keyboard. Yeah.
yeah. Now, uh, so this was a 12-year-old male who presented with an acute uh, traumatic patellar dislocation after sustaining a fall while he was playing football. The dislocation was reduced in the casualty, and he had a similar episode 1 year back, which was then managed non-operatively, and then he was with us again with a similar problem. On examination, he had swelling around the knee and tenderness over the medial aspect of the patella. Apprehension was positive. He had genu-valgum on the left side, which was the side of the dislocation with an increased Q angle. There were no rotational deformities in the form of increased femoral anteversion or external tibial torsion, and the Beaton score was not very high. This is the scanogram where we can see that there is genu-valgum on the left side, and also we got a radiograph of the left wrist where we can see that the patient is skeletally immature. Here the distal phalangeal physis is open, which some papers have reported indicates that the child hasn't reached the peak height velocity yet. So there is at least 2 years of growth that is left. So we need to keep the physis in mind while deciding treatment for him. Coming to the MRI, we can appreciate that there is a avulsion injury of the MPFL with the inferomedial uh, chip avulsion from the patella. And we can see contusions over the medial aspect of the patella and correspondingly over the lateral femoral condyle, indicating the trauma that must have happened with the dislocation and reduction back. Also, the CT scan shows a subluxed patella with a shallow trochlear groove, and we can also see the open physis. These were the radiological parameters. There was 7.5 degrees of valgus with a reduced LDFA with a normal MPTA and increased Caton Deschamps and insol Salvati ratio, which indicated that he had patella alta. The TTTG distance was normal. The cartilage sulcus angle was towards the higher limit of normal at 152 degrees. So the decision making here firstly was whether we should have operated after the first episode itself, which from the previous talk, I think it is quite clear that it is something that definitely needs to be considered. Also, the issues that had to be addressed in this particular child. So obviously, apart from the MPFL injury, he does have genu valgum and he does have patella alta. And in addition, we have to consider that he is skeletally immature with a open physis that we have to take care not to violate. The next decision is whether to do address all these in a single stage or we want to stage the procedures, and also the choice of surgical technique that we'd like to use. Obviously, as ma'am has already said that MPFL reconstruction is the mainstay of treatment, but what other conditions that we want to address at the same time. Also, recent papers have described newer techniques like MQTFL reconstruction, where we try to reconstruct the medial quadriceps tendon femoral ligament. Another very important thing I think that we need to address in this case is, suppose if we decide to address the genu valgum via growth modulation and want to do MPFL reconstruction at the same time, the genu valgum is going to correct slowly over time. So we have to think if the changing alignment will affect the tension of the MPFL ligament that we have reconstructed as the genu valgum reduces. This has already been comprehensively covered in the previous talk that slowly there is a paradigm shift in our understanding of how to treat a first-time patellar dislocation. Uh, 20 years back, studies have showed that there was no superiority in outcomes following surgical management, but recent meta-analysis have been in the favor of surgical treatment. So I'd like to skip this and move on to the procedure as all this has been covered. Some articles that I found showed that patella alta, even if not addressed, the isolated MPFL reconstruction leads to a statistically significant decrease in the patellar height ratio. Uh, as seen in this series, 60% of the cases, the Caton Deschamps index got normalized after an isolated MPFL reconstruction alone. Also, the pre-op patella alta does not significantly correlate with worse outcomes post-operatively. This is another article that we came across which addressed a very similar situation to ours, where there was patellar instability in a skeletally immature child with genu valgum. And this is what they did. They did a hemiepiphysiodesis of the medial side with a PET screw and combined an MPFL reconstruction along with it. And this is the post-operative follow-up, which shows that the genu valgum has corrected. An important tip to note in this case is that growth modulation can also be done with a figure of eight plate. However, as they have shown in the radiograph, it may interfere with the MPFL reconstruction that we want to combine with it. So the PET screw is probably a more favorable implant to carry this out. Coming to the procedure, uh, as you can see, the patient is in the supine position, tourniquet is applied, and this is the patella glide test. You can see the patella is dislocating laterally. So firstly, we did the hemiepiphysiodesis. Here we put the guide wire in a retrograde fashion from the medial side because it is closer to the actual side that we want to target, which is the physis at the junction of the medial one third and the middle one third. The guide wire is then pushed laterally and taken out from the lateral side, following which the fully threaded cannulated screw is inserted in the antegrade direction from the lateral side. Following hemiepiphysiodesis, we proceeded with a diagnostic arthroscopy. Here you can see that the suprapatellar portal was created. An important tip here is to try to create the portal in a slightly oblique fashion so that the fluid does not keep coming out all the time. And this is the view that we saw. The patella is slightly subluxed and not very well sitting in the trochlear groove. We proceeded then with the graft harvest. Usually we use a hamstring tendon graft, and usually gracilis is sufficient. However, in this case, the gracilis was very thin and we have harvested a semitendinosus graft, which was about 24 centimeters in length, and it was then prepared to do the MPFL reconstruction. Coming to the patellar side, here we can see marking of the medial border of the patella, and it is primarily the superior half of the medial border that is of the interest. Also, the medial epicondyle is being marked. We have to dissect down to the layers 2 and 3. So the layer 2 is basically the medial MPFL and the superior superficial MCL, and the layer 3 is the capsule and the deep MCL. So we want to dissect down to between these two layers and do the MPFL reconstruction. Here we can see that the shaver is being used to debride all the soft tissue that may be overlying the patella uh, for the anchors to be inserted. The ideal position for the anchors is the first one at the supromedial corner, roughly about 11:30 or 11 o'clock on the clock face, and the second one is slightly lower at the junction of the upper one third and the middle one third of the patella. Here you can see that the two anchors have been placed, and once they are placed, the sutures will then be used to secure the graft to the patella. Here we are seeing how gra uh, the length was being judged if the graft length is sufficient. Then we move on to the femur, and to identify the isometric point, which has been described as the Shortall's point, we draw three lines. The first one is parallel to the posterior cortex of the femur, following which there are two lines perpendicular to the first line, one passing through the posterior most point of the Blumensatz's line, and one just intersecting the beginning of the femoral condyle posteriorly. And the intersection of all these three helps guide us to the isometric point, which is confirmed on the CR. Once that has been identified, we proceed to pass a bead pin directed from lateral to medial and distal to proximal and posterior to anterior, following which, as you can see, the artery forceps have to be passed through to that point, taking care to stay between the layers 2 and 3, as I have told, and then shuttling the sutures between these two. Here you can see the sutures have been wound around the bead pin, and then the knee is carried out through the range of motion to check for the isometricity of the point that we have marked. Once we are satisfied with that, uh, it is just a matter of fixing the graft between these two. So the graft, after it has been tied to the suture
I request
anchors
you to hurry up a little bit, please.
at the patella. Yes, sir, I'm just done. We drill through the bead pin and then pass the sutures across the tunnel, after which it is fixed with the interference screw. So here we can see that it is now being passed. At this point, we are also using the suprapatellar portal to verify that the patella is back in the trochlear groove, and then the interference screw is being fixed on the femoral end at about 30 to 40 degrees of flexion. This was the post-operative radiograph of the patient, and this was the post-operative protocol. Progressive range of motions can be instituted early. We advise a protective weight bearing for the initial 2 weeks. Strengthening exercises are started from 6 weeks. Thank you all.
Any comments and suggestions?
Excellent management of the case. I think really well. So is it the growth modulation screws was just because of the genu valgum which you picked up pre-operatively, isn't it, Dr. Mithane?
Oh, yes. I mean, I was inclined to do only an MPFL reconstruction, but my pediatric orthopedic colleague insisted that they've been adding this to procedures, and it will help the patient. So
Fine.
he had an argument, then he showed evidence, and he won.
And you'd follow them with long leg scanograms year-wise.
Yes.
Brilliant. Excellent management. Yeah, we can
Right.
proceed.
I think we are running behind time.
Yeah.
So we'll move to the next presentation, please. Dr. Mitali, if you can please share your screen and uh, discuss your case.
Is my screen visible, sir?
Yes, it is.
Yes, Mitali, visible, very well visible.
Yes. So, good evening to one and all. I am Dr. Mitali Mokashi from KEM Hospital, Mumbai. First off, I would like to thank the Indian Arthroscopy Society for giving me this opportunity to share the screen with such eminent arthroscopy surgeons. And today, proceeding to my case, I would like to present this case of a traumatic multiligament injury in a young recreational athlete. So this case is of a 27-year-old male who had complained of instability and pain in the right knee since 10 days after a history of trauma to the knee in a road traffic accident. There was no distal neurovascular deficit, and the patient is a recreational football player. On clinical examination, there was grade 3 anterior draw test, Latchman test was positive, pivot shift test was positive, the varus and valgus stress test were positive, McMurray's and dial test was positive. On getting the MRI done on sagittal cuts, we could see that there was an ACL injury, but along with that, there appeared to be some signals in the posterior horn of the lateral and the medial meniscus. Moving on to the coronal cuts, we could appreciate an injury to the medial collateral ligament at the femoral end, and the tendon of the popliteus was torn. Along with that, there were also signals on the posterior side more inclined towards the lateral meniscus. On the axial cuts, the injury to the posterior lateral corner could be seen. Alignment radiograph seemed to give a normal alignment, and radiological examination under anesthesia revealed a anterior drawer test along with varus and valgus opening to the knee. On getting a diagnostic round through the anterolateral portal, we could see that the ACL was avulsed from the tibial end. On shaving that off, we could see that the posterior horn of the lateral meniscus was also avulsed, but it was reducible. Drive-through sign was positive on the lateral side, and there was no injury to the meniscus. Coming to the medial side, there was an injury to the posterior horn of the medial meniscus. Lift-off test was positive, and this meniscus root was reducible in its anatomical position. The rest of the medial meniscus appeared to be okay, except for the joint opening, which was there on the medial side. Going ahead to plan the surgery, some of the concerns one could have had were the timing of the surgery, if it should be done at once or it should be staged, should one go in for a repair or a reconstruction, and the choice of graft since multiple procedures are needed. We went ahead with a single stage procedure when medial and lateral roots were repaired with pull-through sutures, transosseous pull-through sutures, using fiber tape and fiber wire. Tags were taken on the posterior horns of the lateral and the medial meniscus. Transosseous tunnels were drilled. The tunnel for the posterior horn of the lateral meniscus was drilled on the anterolateral side of the tibia, coming in at the anatomical location intraarticularly. Sutures were shuttled, and fiber tape and fiber wire were passed through the transosseous tunnels. Coming to the medial side, the bed was prepared on the medial side for a good repair. Transosseous tunnel was drilled by an outside-in technique using a zig, and the sutures were pulled through. Exteriorly, we tied the sutures with a suture disc. For the ACL, we used a hamstring semitendinosus graft, which was prepared. The diameter of the graft came around 7 mm, and preoperatively, we had planned to augment it with a synthetic augment Kairos. After using Kairos, the graft gave us a good diameter of about 9 mm. We prepared the graft over an adjustable loop endobutton. ACL tunnels were created. The femoral tunnel with a transportal technique using the anatomical location posterior referencing, and the tibial tunnel was drilled. Sutures were passed and the graft was passed through the tunnels. Endobutton flipping was observed, cycling was done, and the graft was fixed with a biocomposite interference screw. We went on to do an MCL repair where an incision was taken directly over the medial condyle. The tear in the MCL was identified, an anchor was placed, and primary repair was done. For the PLC reconstruction, we used Kairos again. A modified Larsen technique was done, wherein incision was taken over the lateral aspect of the knee. The common peroneal nerve was isolated. Using the modified Arcerio technique, a tunnel was drilled through the fibular head. Around 7 mm tunnel was drilled. The artificial ligament was passed through it and fixed on the femoral side. Here, we had to be careful because the tunnels were to be angled anteriorly at an angle of about 30 degrees to prevent coalescence with the ACL femoral tunnel. This is our graft being secured, and we fixed it with biocomposite screws. We could get a good post-op stability, and our post-op X-ray reveals the MCL repair with a suture anchor, the suture discs for the medial and lateral root repair, and ACL repair, which is done with an adjustable loop and a biocomposite screw, as well as a PLC reconstruction. On 3 months follow-up, the patient is doing very well. He can carry out with his activities of daily living. He has started jogging and has achieved complete knee flexion. Going on to a review of literature, biomechanically, the effect of a root tear is comparable to that of a total meniscectomy. Hence, traumatic root tears must always be addressed and repaired. Lateral meniscus posterior root tears are commonly associated with ACL injuries, and they should be looked for. There are different patterns of lateral meniscus root tears as given by Foucault and Peterson. Type A is just an avulsion of the posterior horn of the lateral meniscus. Type B is a near root radial tear. And type C is an avulsion along with injury to the meniscofemoral ligament. The mechanism of injury is because of the anterior translation of tibia below the femur because of an absent ACL. The posterior lateral corner injuries must be addressed whenever they are associated with a central pivot injury. And since our injury fell into Fanelli's type B, we proceeded with an R0 reconstruction. The combined ACL injuries and MCL injuries can be operated in an acute setting, and it may be potentially advantageous. Thank you.
Excellent presentation, Dr. Mitali.
Thank you.
Just one thing to note that
Yes,
unlike the MCL, the LCL and the popliteus are not isometric structures. The
yes, sir.
LCL may be isometric between 0 to 70, but not beyond. So if you're using a tape that doesn't involve any stretch, you must make sure that it's not very tight because it will lead to range of motion restriction. And if it is not very tight, it may lead to some varus stress opening. So for the
Yes, sir.
MCL, these tapes, like the short isometric construct described by Andy Williams and Andrew Amos and all make sense. But on the lateral side, we must be a little careful. And the founders also note that if you want to use it for the ACL, then we may target the high AM bundle position because that makes the ACL as well a little more isometric than getting it a little on the lower side, more anatomic like the one you described. But great presentation, and you didn't have any tunnel coalition, which is like super.
So,
So,
I would like to quote this article by Moaz Shawl. He has said that if there is an ACL reconstruction being done along with a PLC reconstruction, the tunnels must be directed 30 to 35 degrees anteriorly. Whereas if we are doing with it with a PLC with a PCL, they should be directed proximally and anteriorly.
yeah.
That's great.
May I ask one question? Just one question. Just a very good presentation, Mitali. So, just one question that what is the timing of your surgery, and do you always do CT angio for such multiligament cases?
So answering your first question, since in this case we had posterior root tears and the effect of a root tear is similar to a meniscectomy, we went in early to fix the roots and we were able to do everything in one go. Coming to your second question about the CT angio, we usually do a CT angio only when we do not palpate a peripheral pulse.
Okay.
Hi, Dr. Mitali.
Thank you.
Yes.
It was a very nice presentation. Just one, do you do a fibula-based PLC reconstruction all the time for these multi-ligaments, which is very reasonable? The uh, only time I have felt that tibial-based reconstruction is useful when the proximal tib fib is gone as well. Uh, any experience similar, Dr. Miten or anyone in the faculty with that?
Sir, so I would like to quote this article by Fanelli et al., where they had classified the posterolateral injuries into A, B, and C.
See,
A
yes, yes.
being less than 5 degrees of varus opening and external rotation, B being 5 to 10 degrees of external rotation, and C being more than 10 degrees. So a C warrants a tibial based procedure, while B can be done with a fibular based procedure.
I generally see the hyperextension and the dial. So if you have a patient that has a hyperextension and a dial, like that described initially in one of Rob Laprad's in first papers describing his PLC, if you get that, then that means that, oh, the lateral side's completely gone. Many of these patients, if the MCL is intact, also happen to have a pivot.
Pivot.
Means
Yeah.
that the lateral sided injury is actually going anterolateral as well. I think they deserve a Laprade kind of a reconstruction.
Does Dr. Laurie has to say any comments about the multi-ligament injuries?
No, it was a great job. It's a lot of surgery to do all in one. So the only thing I would say is if you're not as good at them as Dr. Rohan, don't be afraid to stage those also. I think you just have to make your plan ahead of time. I know my partner has a big whiteboard in the operating room and he plans every step, and he's got, if things go wrong, we can stop here. And so it's all very planned out, and that will set you up for success on these complex things, planning out your angles of your tunnels, so all those things. So thinking ahead is important.
Sure.
Okay, next up we have our star. Thank you, Mitali. And we have Dr. Prashant Mishram.
You don't have to, yeah.
Yeah, and Prashant, you're
you
going to
really
talk
hit me,
about
sir.
aggressive cuff tears, buddy. Okay, shoot.
All right, so sorry to crash the knee party, but I really enjoyed the talks because it's been a while since I've attended knee, and I think a lot of it overlaps because I'm really interested into artificial grafts which are coming up, because some point of time we're going to run out of options for shoulders and we're going to put those kind of grafts. So it's good to exchange knowledge on both the ends, even at the knee. So I would like to present very quickly On irreparable rotator cuff tear, I'd like to have it very, very brief. So I wanna focus on something which I've changed in last 1 or 2 years of my practice, in which I use a lot of biceps. I practice in the city called as Hyderabad in India. So I'm also I don't have any financial disclosures, but I'm on editorial board of several journals, and that's how I learn about knee as well as shoulders as well. And this is something which I recommend any of the young guys to kind of start reviewing for journals, so that you can get in these positions, which can really help you to be a good doctor as well. So, in terms of massive cuff tears, you really do have a retear rate of 40 to 50%. And this is one of our papers in which we found this was one of very difficult problems to deal with, on how to deal with massive cuff tears, especially those who are not, you're not able to kind of repair. You see one of these patients typically in your practice, in which there is a massive cuff tear, or poor quality tissue, but patient does not really have any functional demands which require a surgery, so you can just leave them alone. But the issue happens when you have patients like this, who really have a pseudoparesis or paralysis, in which the tendon quality is bad. There's a very bad cuff tissue which is there, and these are the patients which probably you need to operate on. So basically, not every massive cuff tear you want to operate. There's some you need to select your patients, and some of them will get good only with physiotherapy. So in terms of irreparable supraspinatus tear, this is one of the everyone knows probably this word, in at least in shoulder word, Mihata, who came up with superior capsular reconstruction. For the first time, there was reversal of pseudoparalysis without a reverse shoulder replacement. So this was something which was really exciting. And what we have learned over the years since 2018, over 7 years, is that it doesn't matter what you put in that space. If you do a superior capsule reconstruction, if you put an allograft, an autograft, you put a synthetic graft, it somehow works in order to depress the humeral head to some or the other extent. Xenograft are the ones I would really stay away from, but otherwise, we have a decent data to say that superior capsule reconstruction works if done well. So with this, in India, especially when we do have less resources as compared to probably other Western countries, why not use a biceps SCR? It's a natural graft which is there in the shoulder. It acts as a depressor of the humeral head. This is the natural function, even without rerouting or SCR. It acts as a natural depressor. It is mechanically strong. It's an autograft, and there is no morbidity of harvesting from other side. Then it has a natural glenoid anchor, which means one anchor less to use, less cost, and it also takes less time. So with this, let's come to one of the cases, which is a 50-year-old active male, post-trauma, 6 months, and he has a pseudoparesis, which is about he has a lot of weakness. It goes about 120 of flexion, but he's an active male with irreparable, probably supraspinatus and infraspinatus. If you can see, there is a superior migration of humeral head. And these are the guys I like to do a combined procedure in order to read out the biceps as well as do a lower trapezius transfer. So this is how I do my biceps SCR. I put the anchor a little anterior than what I would do because I have to accommodate the lower trapezius graft as well. So this is how I pass using a bird beak. You take a bite in the center of the tendon and try to take out a loop of the suture, go through the loop and retrieve the other end of the suture from it. And we take 1 and 2 stitches. It probably takes 10 minutes extra time from my procedure. And there's one thing which I do rerouting. I don't cut the distal end of the biceps. So I go all the way down until the pect major, making sure that I release whole of the tendon. This is the reason, I found that my patients do not have pain in the biceps because it acts as a tenodesis where it is fixed. And then we can go ahead and do lower trapezius transfer along with this. And I've done this in about 5 of my cases recently. I'm extremely happy with this. And this is something which I would recommend. If you have a supraspinatus, infraspinatus, which is non-reparable, you can use a biceps rerouting and as well as use a lower trapezius transfer. Works really well. This is how the patient is. If you see, there's a immediate reversal of humeral head superior migration, which essentially means we are doing a joint preservation procedure in a 50-year-old active male. And this patient is doing really well clinically as well. Now, biceps SCR can be used as an isolated procedure. I don't do it in each and every patient, but there's few select patients I've found this to be very rewarding procedure. So 65-year-old female, obese, and she's a homemaker. 1 month post-trauma. She has a pseudo paralysis, so has only 30 degrees of active flexion, irreparable supraspinatus tear. but I could, I thought even on the MRI, I could think that I could repair infraspinatus and subscapularis, and there was no osteoarthritis. So she wasn't really ready for reverse, I would say. And 65-year-old female, they wanted to try something other than just a reverse. And this is really critical for me to make a decision. If you see the fatty regeneration is not that bad. So these are the patients we can do a partial repair and augment with something more than just a repair and probably expect good outcomes. So this is intraoperatively what I could find. This is a subscapularis, which is easily coming after releases until the footprint. This was, sorry about that. Yeah. So on the right side, what you can see is infraspinatus, which is coming. But in between that, the anterior part of especially supraspinatus was not repairable. So after all the releases, I could find that, okay, I'm able to repair the infraspinatus and subscapularis. So only thing which I did, this is on the left side, what you see is a subscapularis repair. I do an all inside in most of my cases. In the middle, what you see is biceps rerouting, exactly done the way I showed it in the technique before. And this is how the cuff, which was mostly infraspinatus, which was, I could bring it and cover the footprint as much as possible. How biceps as rerouting, don't cut the distal end, is probably it acts as a protective layer, which helps for depression of the humeral head and also protects against the re-tear of the infraspinatus or whatever partial repair you have done. So this is how the patient, there's a reversal of pseudoparalysis. This is just 3 months. And this is one of the typical short females which we have, do not have neck, and we're also always afraid they will have a re-tear because of multiple comorbidities and everything else. But she's doing excellent. Just a few of the prominent studies in this particular area. So this was introduced, biceps SCR was introduced in 2018 was the first paper. It was actually introduced in 2000, in which they did an open procedure of getting a biceps and putting it down in the center of the tear. And all the 9 patients with irreparable tear, they had improved function, no complications. Now people started to use it in different ways, and they wanted to make their own configuration. So this is a Z technique in which this is out of Korea. 87% of graft healing. Again, they cut the distal end of the biceps and did a subpectoral tenodesis. So that worked really well. But then recent studies have been about rerouting, in which you do not cut the distal end. And this is very, I was very glad to because this is the procedure which I use right now. You either make a tunnel, if you don't make a tunnel, but if you reroute it, it acts as a depressor. And the re-tear rate, they were able to get it less by I would say like about 80%, which is probably acceptable in these massive cuff tears. Another paper from Larry Field recently published 33 massive cuff tears. They in this, they had only one biceps rupture. And if you see, it is, some people say that you do a biceps SCR and the biceps is a thin tendon, it cuts out. But actually this paper shows that whatever they could achieve the function at 6 months is actually sustainable 1 year and 2 years. So the function is actually sustained if the graft heals really well. Now comparing the biceps SCR, which is on the left side, you do a partial repair and a biceps SCR, as compared to the tensor fascia lata, exactly as shown by Mihata. And this paper actually found that the function was same. The acromial humeral distance was same. The only problem I have, and probably this is for the future, is that they did not compare the power, the muscle power gained in both. I'm guessing that patients who had tensor fascia lata probably had better power, but we don't know. That is something for the future. Now, what are the patients in which you do not want to do a biceps SCR for a large to massive cuff tear or irreparable tear? Is anyone with a biceps which is torn more than 50%? Those are the patients, probably the re-tear rate is really high, and those are the patients I would not do it. But most of the patients, I find that it is intact to an extent that I could reroute it. So take home, I think it has become a part of my practice, either as an augment or as a single procedure, depending on the patient profile. But I do them in irreparable supraspinatus tear, especially when subscap and infra are reparable. No osteoarthritis. And pseudoparalysis for me is not a contraindication, but the biceps must be intact for more than 50%. And I do not cut the biceps distally. Thank you so much for the organizers for having me, especially Neha and other organizers.
Thank you.
Thank you, Prashant.
Prashant, excellent presentation. Superb work. Any indication where you augment this biceps SCR?
Augment the biceps SCR? Yes, I do. So the thing is, if only supraspinatus is gone, and if the patient is, say, 50 years old or more active labor manual I still tend to do the tensor fascia lata or any allograft. I've recently started a lot of allografts, because they are available in India, and the initial scare which we had that they have infection, I have not found that in my practice. It also gives me confidence because of my training outside, that when I was using allografts in US and also in Dubai, that gave me, and also in Korea. So for ACLs and everything, they use a lot of allografts. So that gave me confidence that in India also we can use it. So I use a lot of allografts in those cases. If supraspinatus is gone, then I would put an allograft on top of it, just like Mihata said. If supraspinatus is gone, but the patient is really, what I showed, older individual, probably less demand, I would like to reroute the biceps alone, along with the partial repair. But if the supraspinatus and infraspinatus both are gone, I'm inclined to do a lower trapezius transfer. That has been my go-to. So, I use it, it's like one very good tool in your armamentarium. It's like your favorite hammer or your favorite ranger, which you have. You always take it to all your surgeries, you take it to war. So this is something which I'm doing with biceps SCR. I think I'm using it as an augment or a single procedure depending on the situation.
Just to continue on that, what about irreparable supra and infra? Would you get away only with the lower trap transfer and not do an biceps SCR?
I have done that. If the biceps is intact, I would do a rerouting procedure. But one of the cases which was done, I think 2 weeks back, I did not have a very good. In fact, the bicep was gone. She was living with that for 5 years, and because what happens in biceps is, in initial stages, after 1 or 2 years, it becomes hypertrophied. So when we're doing for cuff arthritis, if you're doing a reverse, you always find this thick biceps, which almost looks like a supraspinatus tendon. So it becomes hypertrophied because it is taking the load of supraspinatus not being there, right? But eventually it gives away. So this was one of the patients in which it gave away. I couldn't find it. I did only lower trapezius transfer. So the way I do it is, I use tendo Achilles graft, and this is very thick. It's about 2.5 centimeters. It covers most of the footprint. So instead of putting it little back, I try to cover the supraspinatus as well. I know it's not the perfect solution, but for me to do tensor fascia lata SCR plus lower trapezius, I think it's too much. I know people who do that, but as Laurie was mentioning, you need to know your limitations on how much you can do in one procedure. So for me, if supraspinatus, infraspinatus is gone and patient is, I don't want to do a reverse, then I would definitely do only lower trapezius transfer, but make sure that the graft which you're using is really thick to cover it. I would not like to use a hamstring for that. If I'm using an autograft, I would probably use peroneus for that. That's a really good thick graft. Or in allograft, I would use tendo Achilles.
Excellent. Thank you.
Can I ask one question?
Absolutely. With the Bosch.
Yeah. So basically, if there is bicep fraying, so would you, or maybe it's inflamed biceps, so would you still go ahead and do biceps rerouting, or
Okay.
would it give away? Yeah.
That's a fantastic question, because a lot of people, so I was trained in US. That's different from if someone's trained in France. What they do is, when they put in the scope, they probably trained into, I don't want to say a country, but it's a philosophy. So they just go in and they cut the biceps and then they open their eyes to do anything else. I don't like that. I have stopped doing that, like, categorically. I had one patient, in which he had full range of motion. He just had weakness, massive supraspinatus tear. I cut, because he was old. I thought I'll just cut it and move on. And that was the patient who had a pseudo paralysis after the surgery, because the supraspinatus gave up, that he had a re-tear. And the only thing which was holding was biceps, and I cut that as well. So I save biceps. Nowadays I go inside, I check whole joint, because you never know if you want to use it as for rerouting for SCR or whatever purpose. So I don't cut it. But why I don't, I have always been a biceps stenosis guy. So I'm never a cutting, I'm not a cutter. But when you actually reroute it and put it in the center, that anchor point acts as a tenodesis in itself. So the proximal part is probably acting as an SCR or giving support for the humeral head depression, and the distal part and whatever angle you have, that is your tenodesis. And if there's one point in which patient had very significant synovitis, or if you want to call it like a lot of inflammation, you can add another anchor distally and do kind of like a double fixation for biceps. Another thing which I do is, if you use an anchor by one of the companies, which I don't want to name, but they have an extra anchor in the lateral row. Sorry, extra suture in the lateral row. So you can use that as a distal fixation. You don't have to use another anchor. All you use is, once you fix your lateral row, you just use that extra thread and tie down the biceps there. So, and the only thing which I do is I don't allow them to lift anything heavier than a coffee mug for about a month. But I start the range of motion for biceps immediately.
So Prashant, as Neha asked, if it is inflamed biceps, then also you will not plan for tenotomies. Up to you see the fraying there, some inflammation is there in the biceps. So then also you will reroute the biceps.
Yes. So in normal cases, when we are not talking about massive cuff or patient a small cuff, and I'm not really trying to incorporate biceps, even in those cases, I would do bicep tenodesis. As I said, that I like to do bicep tenodesis unless the patient is very old, which is 70 or something like this. I really like to do a tenodesis in suprapectoral kind of region, arthroscopically from subacromial space. So even if it is inflamed, I would fix it there. I think the cramping pain which patient is having for 3 months is not there. Tenotomy for me, for some reason, for my cases, when I do tenotomy, they have this cramping pain, and their initial experience for 3 months is not really that great. So I like to fix it if it's inflamed. One thing which I do is, as I showed in my this thing in a video, is that I go all the way down to pec major and make sure that I release the whole of the sheath around the biceps. That probably gives you a breather and reduces the pain. So luckily, I've not been having issues with biceps pain even after
Yeah.
TNOD.
So you are doing decongestion of the bicep by releasing the sheath. Yes.
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 Absolutely.
Just from a knee surgeon's perspective, when you do all these massive cuff tear repairs and stuff, do these shoulders grow old, get arthritic at some point? Like, is there evidence to say that plain cuff tear moves to arthropathy at X point, and then if you do massive cuff tear repair and all of this, it doesn't get arthritic then?
So if you're saying that, so if I get the questions correctly, if there is a lot of people who have a cuff tear who live without any symptoms, goes unnoticed. It is only when they have pain with the biceps or something, you get it and you find it, or the patient actually has to. And that's why I said my first slide was a lot of people will have very good function even with a massive cuff tear. So you don't have to do surgeries in them.
And they'll present maybe at some point with arthritis.
Yes. So if yeah.
So if you have these massive cuff tears that you've repaired, or you do these lower trap transfers, etc., do they avoid the shoulder arthropathy and a shoulder replacement later on in life?
Yes. So I would say something like high tibial osteotomy, which is joint preservation. So all the patients who have high tibial osteotomy doesn't mean that they will not have arthritis. It probably what you're doing is we are just balancing the force couple in shoulder terms. If their shoulder is trying to go up and we're trying to depress it by doing anything, you can put an SCR, you can put a lower trapezius transfer. So once it is depressed, that probably for me is prevention of progression of
So
arthritis.
do you always only sell symptom improvement, or you also sell like long-term good outcomes?
So, everything is a symptom, like weakness is also a symptom and everything else. But when I'm talking to the patient,
Surgeries are all done to improve symptoms of the
yeah,
patient.
yeah. But, I get your question. So when, if someone comes to me and I only find it on MRI, they have a massive cuff tear, I don't tell them that, oh, you should get a surgery because you may develop
Correct,
arthritis.
correct. That was
That's the
my
question.
question. It's like I mean, I was just drawing an analogy with root tears. If they are not symptomatic, do you actually offer them surgery such that, oh, you won't get knee osteoarthritis?
No, I don't do that. I don't really, there's no symptom. I don't even, I get everyone gets an X-ray. But if there is no major symptom, they don't even get an MRI. And I don't really think, because a lot of people, as I said, they live their whole life with a cuff tear. Like, it's like a finding which above 60 is probably 30% or 40%. It's like AC joint arthritis. It is,
Wow.
you cannot kill someone for having white hair, right? So it's a part of the aging process.
Right.
And I
So as
think,
long as they're not symptomatic, don't touch them, huh?
absolutely.
Okay. Okay. Super. Okay. So all those who are listening, great points made, right? And this has been a wonderful session. I mean, before I just hand it over to Neha and Naresh, Rohan, it's so good to see you after so many years. And I thought that the presentations today were really fabulous, and they raised the standards of the IAS webinars. Aditya, Mitali, was Prashant. Dr. Rajiv has been listening to at least around 50 of these IAS webinars. I would want his opinion. I think his standards were very high, and there's been a lot of learning for all of us. Rajiv, sir.
Yes, yes. Thank you, Miten. I think Neha and Naresh, the whole team has worked hard. And thanks for a wonderful webinar. It was very much informative for me also. So over to you, Miten.
Yeah, so Neha and Naresh, can't thank you enough for taking all the efforts to get us all on one page and having us here today. Thank you, Neha.
Thank you so
Thank you,
much.
Neha.
Thank you.
Thank you, Dr. Neha,
Thank
for inviting. Thank you, everyone, for
you,
inviting. It was
Dr.
wonderful to meet you all
Yeah.
virtually.
And yeah, it's a lovely webinar today. All the cases were outstanding, and Dr. Laurie also presented, and actually she presented well on the first time dislocators because it's a very confusing topic, and she has shed a lot of light on it. So thanks to Dr. Laurie and thanks to Dr. Rajiv Raman sir, our secretary IAS, for joining us. So I think that's for the evening. Thank you.